Hello, everyone. I'm Steve Myers, Managing Editor of Digital Health Insights. Welcome to today's webinar, Digital Health Impact on Health System Employer Partnerships and Pop Health. Today's event is brought to you by Xealth, a great partner of ours that brings some great content to this audience. We welcome you and thank you for being here. We have about an hour. So I want to give a few quick notes so you know what to expect from today's event. It is being recorded, so you'll have the ability to access this on demand, as will anybody who signed up but were unable to attend live, or if you missed part of it live. So on demand, being recorded, you'll have access to everything. We will have some time at the end for Q&A, so please use the Q&A function to submit any questions. We'll gather them and get to as many as we can at the end. If we don't get to your question, we'll for sure pass that on to the presenters so that they can check out what your question is and get in touch if it's with an answer. We will monitor the chat in case a question pops up in the chat, but the Q&A function is the primary place to submit a question, and we thank you for that. So real quick, how we'll go about today is we'll have a short presentation from Scripps and Xealth, and then we'll have what we call a fireside chat. We'll bring in our Digital Health Analytics Vice President, Lauren Pettit, who will guide that discussion. Following that discussion, we'll have the audience Q&A that I mentioned. And so with us today, they will be giving you some more information about themselves and their organizations, but just to lay the groundwork, we have Tracy Chu, who is Corporate Vice President of Pop Health and ACO Chief Executive for Scripps Health. We have Aaron Sheedy, who is COO and co-founder of Xealth, and as I mentioned, Lauren Pettit will join in a little later, Vice President of Digital Health Insights for Chime. So I'm going to hand things over to Aaron so we can dive right into this content, and he'll take it from there.
Yeah, great. Thanks, Steve. And just to reiterate, I think Tracy and I both really want to encourage folks to ask questions at the end. We want to save enough time for that because it's, as smart and as intelligent as we are and fun to listen to, it's going to be a lot more interesting if you guys can get your questions out there and we can answer them directly, because a lot of cool stuff in here that Tracy's going to go over. So by background, as you can see on this, I'm the COO and one of the co-founders of Xealth. So really appreciate Chime having us here today. But most importantly, happy to have Tracy here representing some of the work that we've been doing together. So just a really short little bit on Xealth for those of you that might not be familiar. So we're about a 5-year-old company. We spun out of Providence. This is my 5th startup, but my first healthcare startup. So you can tell what happened to me when I started healthcare. My eyes got worse and I look a lot worse than I do in this picture. So thanks for that. But no, I mean, what we found when we actually went into Providence as a set of entrepreneurs is a lot of really great work trying to get digital health deployed at scale, right? People are really expensive. One of the most expensive things in healthcare. That's even more true now than it was 5 years ago. Whenever you have an industry that's in that state, trying to digitize things that you're doing on an analog basis is always a really smart idea. But even at large systems like Providence and UPMC and some of our other customers, despite a lot of work that they were putting in place to try to create good clinical experiences, to try to build good IT and IS processes to operationally manage digital health and trying to create great patient experiences, we found a lot of organizations struggling to do that. And so we built Xealth, basically to act as a platform to help integrate digital health solutions, both for the benefit of the IT and IS organization, as well as the clinicians who can easily and efficiently use it or automate the delivery of it so that we can take clicks away entirely. And then ultimately, we're doing that for the benefit of the patient and getting them engaged in the right thing. And getting them engaged in the right thing is different in some environments where you're looking to try to get people to come back in for procedures post-COVID, for instance, or in the case of what we're talking about today, in a more population health sort of story, when you're at risk or you've got a relationship with an employer and you're trying to manage the longitudinal costs of employees/patients, then your goal might be a little different, engaging them in something that really helps them manage their own health or work more closely with their caregiver to manage health. So that's kind of the topic today. We started working with Scripps about 18 months ago with a lot of these ideas in mind, like how do we help them be more efficient in bringing digital health solutions to bear for the benefit of their patients, their clinicians, their IT&S staff, and their partnership with Qualcomm. So with that, that's a little bit about us. I'll turn it over to Tracy, who will take us through, what we've done together over the last year.
Great. Thanks, Aaron. And thanks, everyone. Really excited to be here to kind of share what we've learned so far. We're a little early in our journey, but I think we do have quite a bit of information to be able to share with you, kind of give you a sense of the work that we've been doing with Xealth and some of the early successes we've had. First of all, really quickly, my name is Tracy Chu. I'm the Corporate Vice President of Population Health and the Chief Executive of our ACO at Scripps. In terms of background, for those of you who are not familiar with Scripps, we are an integrated health system. We have about 5 hospitals, 30 clinic sites across San Diego, California. As Aaron kind of alluded to, the purpose of today's conversation is really about focusing our discussion on our relationship that we have with a local, national, and worldwide company, Qualcomm. I think many of you know that name. Approximately 5 years ago, we became the direct-to-employer provider for the Qualcomm patients that are part of their risk-based ACO plan, specifically in San Diego. In this partnership, we share both upside and downside risk to improve clinical outcomes and patient. We have very high levels of customer service and access standards for the patients. Currently, we have about 16,000 Qualcomm employees and their family members participating in this plan. I'm excited today to be here to kind of share the partnership we've had with Xealth to try to improve the access of our Qualcomm members to the services and offerings that we have for them. So if we can go to the next slide. Really quickly, I'll spend a little time on this slide just because I want to make sure people understand kind of the framework in which we kind of looked at Xealth and how we would approach our problem solving with them in mind. Going to go through the next slides pretty quickly. So I want to make sure, like Aaron said, we save time for the panel discussion. So I'll talk pretty quickly through this and let me know if, well, you can put in comments whether or not you want me to slow down. Several years ago, as Aaron alluded to, or several months ago, we decided to partner with them because really the functionality that Xealth allowed us to have kind of helped us answer these 3 questions I think that are really key. 1, how do we make the health system easier to navigate and the population health and care programs we currently have easier for patients to access? 2, how do we make sure the processes for our clinicians to match our patients to the right level of care and the right time easier? And 3, how do we automate and create efficiencies in our system given so many programs and care options? So those are the 3 questions that we really use to base our discussion around Xealth and to see whether or not it made sense for us to partner with them. At the time, we knew that our barriers within Scripps, we knew what the barriers were. We knew that we didn't have solutions to solve them. And so again, we looked to Xealth to say, how do we help? How does Xealth help facilitate removing those barriers? So a couple of things that we knew. We knew that we had patients who were not taking advantage of programs or offerings that they were eligible for. We knew we had many disparate programs for different patient populations that made it virtually impossible for our busy clinicians to know what to offer to whom and when. We knew we did not have a mechanism to provide individualized care to our patients based on their current needs and their health plan. We also knew we were not as proactive as we'd like to be in managing our patient care. So given that was our challenge, what did we do? First of all, initially we focused on the population health programs that we already had in place. And we had barriers to getting patients enrolled or engaged in those programs. We also decided to focus primarily on a lot of our Qualcomm partnership and members because we had a really close relationship with the leadership there, with the benefits team. And we knew that they had high expectations of service and experience for their members. So we knew that we would get real-time feedback on what was working and what was not working with these programs. So the outcomes and the results at a very high level, based on our partnership with Xealth so far, have been that, and I'll go through more detail by use case of kind of the outcomes and then the learnings, but I just want to give you a high level of what we've learned so far and the outcomes. The outcomes we've gotten so far is that we've seen overall improved engagement from our patients. We know that we've been able to improve workflows for our clinicians, our patients, and our staff. We've been able to replace a lot of manual processes with automated ones. And we've also been able to proactively target, communicate, and educate to our patients. So it really does answer those 3 questions that we posed at the beginning. And then the lessons we've learned so far, again, at a very high level. The most important one, we had to keep the patient at the center. How do we use Xealth to make it easier for them? Also important, how do we do this while integrating it seamlessly within the workflow for our physicians and our staff to ensure success? The other lesson we've learned is we needed to keep the scope of the initial work targeted to really focusing on the existing barriers, like removing manual processes, just to make sure that we could leverage the power of Xealth in the best way possible. Third, we knew that Xealth was not a solution for every problem. However, given the flexibility of their functionality, we could customize it and use it to kind of target very specific barriers that we had in enrollment and engagement. Another lesson learned, operational leaders and workflows must be front and center in our work. It's all well and good to have a great solution like Xealth, but if your teams aren't bought in and it creates more work for them, it will fail. 5th lesson we've learned is we need to keep all the members of the team involved. It's not an IS project. It's not an operations project. It's not a population project. It's not a physician project. You've got to create a structure initially to have all those folks involved in a governance process that ensures that integration of work at all levels. And then two additional lessons. 6th one is we need to make sure we had clearly defined KPIs. We needed to know how this intervention, this work would actually improve certain indicators of success. So that was really important, and we need to keep them simple and very targeted. Sometimes we take too much time to try to measure too much. We wanted to make sure this is very simple, and you'll see that in subsequent slides. And then the last lesson we learned is we need to ensure that there was a robust communication strategy so that every level and every tier in the organization knew the value of what we were doing. So those are kind of the high level lessons. If you could go to the next slide, I'll talk through our first use case with Xealth, and this is Baby Scripps. So at Scripps, we use Baby Scripps, which is a third-party app that provides education and adherence to care plans to our Qualcomm and other OB patients. So this is a specific app that really focuses on our OB patients. The problem we were having is that while we knew the app was very valuable, and we've been using it for several years at Scripps, we were struggling to get patients enrolled. We were struggling to get them enrolled and engaged in the app. And part of the reason we were having such problems is a lot of the enrollment was manual. It required our physicians and our staff to actually enroll the patients. It also wasn't being rolled out very consistently across our clinics. So again, the lack of consistency and the manual process made it very difficult for us to get this patient base enrolled into the application. So what we did is with Xealth, we tried to address these challenges. We took the manual process of enrolling patients at the time of their OB visit away from the clinician and the staff. We took the education, introduction of the app itself away from the clinicians. And we did this by proactively sending patients education and information about the app ahead of their appointment. Xealth allowed us to target patients based on their current status and their appointment schedule, and then target the communication specifically around that. The way we use Xealth, it also allowed us to have the patient enroll directly into the app once they received that email communication. So no longer did our staff have to actually enroll the patient and go through that process manually. It saved a lot of time for the staff. And to be honest, it also really enhanced the visit that the patient had with the clinician, because they weren't spending all the time talking about the app. They actually got to spend time talking about their care. So the outcomes from that, and you'll see that on the slide that you have in front of you, are pretty robust. I'm not going to go through all the details of what's on the slide, but I think I want to call out 2 really key areas of improvement. One, we saw a 300% increase in the number of patients enrolled into the app. And you can kind of see that just on that graphic there. A 300% increase is pretty significant in a very short amount of time. We also saw about 290% improvement in the engagement of the patients in the app itself. So you'll see that number on the side, the 11.5 sessions per user per month. Really that indicates is our users were going into the app more because they were educated on the value of it. And so they were engaged more in the actual work of the app. That compared to the baseline prior to using Xealth, which is about 3 to 4 per month. So the engagement and enrollment increases were significant. Bottom line, what we learned out of all this was use Xealth to make it easier for the patients, for the providers and the staff. The engagement will follow. And I think it's a very simple lesson to learn, much simpler to achieve once you actually kind of keep that scope pretty small. So I'm going to ask the next slide. We'll go through the next use case here. Is what we have done specifically with Qualcomm. So, part of our Qualcomm partnership is they have several different third-party vendors that they use to support their health coaching, diet, nutrition services, and behavioral health services to their members. It's Lyra and Vita are the third-party vendors that they partner with. The issue we were having, similar to Baby Scripps, was that we were having low enrollment and engagement in the patients to get actually enrolled in these programs. Our clinicians weren't always aware that the Qualcomm patients were eligible to access these programs based on their benefits. So it became a kind of a mismatch with the clinicians trying to know, oh, you're a Qualcomm member, we need to make sure that you have access to these programs. So again, similar to our prior use cases, what we did was we leveraged Xealth to proactively identify, educate, and communicate these offerings to the Qualcomm members. Xealth allowed us to kind of have an easy access for our patients to also then register and enroll into these programs. So again, that very seamless, automated process that takes the clinician a little bit out of it and allows the system to really work to proactively send that information ahead of time. So the outcomes that we saw related to this, again, on the slide here, so I'm not going to belabor all the details here, but I think it speaks for itself. We were able to expand our number of targeted patients by enrolling, using the kind of algorithms that we worked with Xealth to identify eligibility, send emails directly to the Qualcomm members, and then where appropriate, really kind of expand the use cases. So previous to that, we were really dependent on patients coming into the office to identify them. Now we could expand that to all of our Qualcomm members who are eligible, which created, increase the denominator of patients who are really getting information about these programs. And as a result, we've seen increased engagement, enrollment into the programs. We know once they're engaged and enrolled, these programs work. The issue is getting them across that hurdle. And again, the learnings from this, similar to our Baby Scripps experience, is that if we make it easy for the patients to access these programs and become educated about the value of them, it increases their engagement. And ultimately, this is why we're doing what we do. It improves the clinical outcomes for those patients. So next slide is our last use case. And that's really with continuous glucose monitoring related to our diabetic patient population. We're halfway through this rollout. So what I'll say here is that we really at this point don't have a lot of outcome data and learnings yet. We just rolled this out the end of September, early October. So we're still in that early phase of implementation. I wanted to call this out though, because I think from a population health standpoint, our diabetic patient population is a key area of focus for us. We know that chronic care management and diabetic patients really drive a lot of our work in making sure that we keep patients healthy. So we wanted to make sure we had an use case that really targeted this patient population. What we did here is, like many organizations who are deploying the continuous glucose monitors, is we wanted to, we've been struggling with trying to integrate all the various devices and all the information that comes from those devices into one place and integrate that into the patient care record. The device itself is also based, the patients get access to these devices based on their health plan. So they have various options. And because of that, and each device had its own individual app. So it was really hard to integrate all these, individual apps and individual devices into a single platform that would then allow us to get that information and bring it to our clinicians so they could really take care of these patients. So what we did here, it's a slightly different take on how we've approached the problem solving with Xealth, is we've leveraged Xealth's API and using Remedy, which is a platform that basically takes the information from the various vendors and the devices, aggregates that, and then uses that through the Xealth API to then bring that information directly into Scripps. And so it's kind of a really, it enables us to kind of get all this disparate information that's coming in from all different places, and then brings that into a place that our clinicians can then really use well. And it helps identify patients proactively who are eligible for this. So it's a really elegant way of being able to deploy CGM technology to our patients, which we know is a critical part in managing diabetics. So that's kind of a bit of a primer, a lot more to come on this one. I will say that we've only started this with a very small pilot. We've got a handful of clinicians, and we've really targeted patients who are already on a device. Our next phase will be expanding, obviously, to the rest of our clinicians, as well as new patients who enroll into the CGM devices. So a lot more on that one to come, but I just wanted to at least give you a sense of some of the additional work that we're doing with Xealth related to education and bringing kind of that population health strategy to patients in a much easier way. So I talked really fast. It doesn't conclude my portion of this presentation. I'm hoping it at least gave you a flavor of the work that we've been able to do to improve our care with our Qualcomm patients. I can tell you, having spoken to our Qualcomm leadership team that we work very closely with, they've had very positive feedback. They found this to be a very elegant solution. We have been struggling for years trying to get an increase in the engagement enrollment of the Qualcomm members into these programs. You can see just based on the very early data how remarkable the increase was just by making it easier for everybody. And I think that's kind of the leverage and the use that we continue to look to Xealth to help provide and facilitate, is how do we make things easier for us, for our patients, for our staff, for our clinicians, so that we're not creating artificial barriers to getting them engaged. So with that, I am going to hand it back to Aaron so that he can kind of provide any last comments or additional information related to our use cases.
Yeah, thanks, Tracy. Yeah, I mean, it's hard to add to that. I mean, there's nothing more valuable than hearing it from the leadership at a health system that's actually using your technology and our partners' technology, right? Xealth really is only as good as the various digital health vendors that are integrated into our ecosystem. And so it's great to find really strong partners and see that they're making a difference clinically and to the patient's experience and hopefully ultimately to the overall cost of care. The one thing I will say before we jump into the panel is, Scripps is a really good organization to work with. I mean, like probably almost all of the systems, the IT and IS staff is strong. They've got great clinical leadership. They have patients who want to be engaged digitally across a whole range of demographics. So that part is perhaps not unique. What we have found amazing about the Scripps organization is their commitment to really strong governance. Tracy was talking about, like, this isn't just an IT and IS project. It's not a project for the doctors. It's a project for the system itself to strategically engage effectively, both with the employer's relationship and with the patients for the benefit of the whole system. And I just think that's a really good way to talk about it, because we find a lot of systems getting stuck on governance. And it's just really good to see a system think about it strategically and operate a digital health formulary in the way that we think it should be operated. So it's been a great partnership. And I think with that, Lauren, let's go to the panel stuff so that we can get a little more interactive here.
Okay, thank you, Aaron, and of course, Tracy. That lays such a great foundation for this panel that we'll get into right now, this sort of fireside chat. And as I mentioned, we wanted to bring in our own Lauren Pettit, who's Vice President of Digital Health Analytics, and specifically, leads our Digital Health Most Wired survey, because there's some relevant findings there that he'll use to color the conversation. So I'm going to hand things off to you, Lauren, to get this panel going.
Great. Thank you all. And Tracy, I love the background because I'm in the middle of a storm right now. So if my tech goes a little wonky, I want to be right there.
This is a live feed, just so you're aware.
Yes, absolutely.
Rubbing it in for us up here in Seattle, where it's raining and 50 degrees. So yeah, thanks, Tracy.
No
Very
problem.
Tracy, that was actually, again, very impressive review. And again, I know it has raised a number of questions for those that are in the audience. And again, just remind folks once again, if you do have questions as we go along with this part, and feed them into the Q&A box, and we'll get to those shortly. And while we do, I wanted to again sort of set up here for our conversation. And as one who oversees the Chimes Digital Health Most Wired program, I think it's very significant of having this conversation. Now, for those who are not maybe aware of the Digital Health Most Wired program, it's a digital health strategic planning and recognition program for healthcare organizations, and it's global. We have organizations that submit findings or their IT capabilities through our tool throughout the world. And so it started with the American Hospital Association back in the 90s, and Chime acquired it a few years ago. So when we talk about organizations being recognized as a most wired organization, I mean, it truly is one of those things that the hospital leadership really covets, and they're really sort of are going after. Again, I'm sure some of our folks here today have organizations or represent organizations that are most wired. And again, Scripps, no surprise that you folks have constantly performed well in the program. And Tracy, that includes performance and population health. And so I'm not sort of blowing smoke here when I say that it's truly an honor to be speaking to somebody that is really a leading voice in population health in the world, and we have the evidence to prove that. So again, just thank you for this time here today. Really sort of want to pivot to one of the things. Again, there was a lot of things that you talked through, and I'm just going to bring in sort of one of the frameworks that we use in the Most Wired survey around population health. Is we're looking at digital health technologies used, and we'll call it into like 6 types of population health activities: data aggregation, data analysis, care management, administrative and financial reporting, clinician engagement, and patient engagement. Now, as you were going through your presentation, you obviously touched on some of those areas, and there were sort of learnings, but really, using that type of framework, Tracy and Aaron too, I'll sort of ask you, to sort of, if you want to sort of talk us through some maybe additional learnings that you have in addressing some of these different areas gained using that sort of framework to understand population health activities.
Sure, happy to. First of all, I'll kind of touch on the care management piece, because I think, like many organizations, we have central services that really support a lot of the care management for our patients, particularly around chronic disease management or remote patient monitoring, et cetera. So we have that infrastructure in place. I think where we can, again, continue to struggle is, how do we make sure all the patients that were eligible, that should be participating in this, get access to this? So that was really the biggest barrier for us, is making sure that we had that broader view of the patient population, and making sure we were able to affect the patients that really need to be affected. So using the Xealth platform and using kind of digital technology to help identify and then proactively reach out, and then enable an easier communication pathway between the care management team and the patient, is, in my mind, what we should be doing in everything we do when we look at digital technology. How do we make things easier and remove barriers for patients to get access to care? And I mean, I think that from a population health standpoint is always the biggest barrier for patients, is getting them engaged in and really enrolled in these programs. From an administrative and financial reporting perspective, we've got so many different systems that give us different information. And again, I try to keep things as simple as possible because I think we can overanalyze anything. We're really good at overanalyzing things, and we're really good at looking at all sorts of data. The question in my mind has always been, how do we make sure that it's not just data, but it's information that tells us something that we can do something with? And so working with Xealth and working with other digital technology companies to say, tell me what I can learn from your systems and your reporting that will enable me to change, not just give me a bunch of information I already know, but to change the way I actually care for patients. And I think the data that you saw, as brief as it was, really does kind of reflect that with Xealth. Is we were very targeted in making sure that the KPIs and the measurements and the reporting that we did was really focused on showing, improvement for our patients and our systems, financially, quality-wise, all the things that are important to us. And then I kind of already talked about the clinician and patient engagement, so I probably won't go into that. And then the last thing I would only say is that from a data aggregation standpoint, we think people want it to be perfect, meaning you want all this information to be interfaced and integrated fully into your EMR. What we've learned is that working with Xealth, you don't have to have it to be fully integrated for it to be valuable. So we don't have full integration of all the data that's coming in. A lot of the data still sits in the third-party apps. That's okay. I think that's the piece that we need to recognize. We don't have to have everything flowing into our EMRs. What we do need to do, though, is make sure that what is flowing in makes sense and that we're getting the information that's relevant so that we can take care of the patient. And I think that's the piece that we tend to get stuck on as organizations or as population health leaders is we want everything all the time. We want all the information. You don't need to have all the information to make an impact to our patients.
Yeah, I double down on that last bit because it's the thing that we pride ourselves on being able to pull off, but find ourselves having to explain many times to our health system customers. So that's why it's so nice to have Scripps. So that you don't have to put it all back in the EHR. That's one of the most expensive places on the planet to put data. Just put the right piece that actually needs to be there, either for quality metrics or because of governance or because it needs to be in the legal medical record, and then leave it alone because you've already got partners like Baby Scripps and Remedy and the other vendor. They've already done a really nice job of visualizing the data. And we can mesh that right in one screen. You can go in and click and see exactly how the mom's doing on Baby Scripps. You can check her blood pressure. You can check her readings. You can check everything that Baby Scripps knows about her and see it all in one dashboard. And then you can click over and see your mental health dashboard right next to it. But that data still just lives on the vendor's ecosystem. And of course, on a daily or weekly or monthly basis or whatever, you can dump all that data back in some nice flat file data warehouse so you guys have it all. And you can run nice longitudinal analytics on it. But when it comes to the clinical experience, blend in the best of a vendor who's already done a nice job of visualizing the data, and then what needs to be in the EHR, but just enough. And it's that balance, I think, that really enables us to make a lot of progress, get good clinical experiences, make patients feel like we understand where they are in their journey, and not be going back to the IT and IS staff and asking for another 1,000 hours of work to go put stuff in there that doesn't really need to be there in the first place.
Very good. Very good. So, we live in a digital health world, and this is my space. Aaron, I know this is a space you live in a lot, but we know population health is more than just digital health. Yet, it still is a real significant part of getting these things working. And I think, again, you may have touched on some of this, but again, when you think about some of leveraging digital health in your population health efforts, what would you sort of pinpoint for those that are on that sort of beginning of the journey? Where are the challenges? What should they be sort of looking out for at this juncture?
Yeah, I'm going to sound really redundant here, but I think when it comes to population health, the improved expenses or the improved total cost of care isn't always evident, and it usually takes a while for you to see the results. I mean, having an impact on our diabetic patient population today may not actually yield results for a couple of months or years, and you're not going to see that. So a lot of us, want to see those results immediately, and population health is a long-term strategy. It's not a short-term. You're not going to get short-term gains oftentimes, and so trying to create interfaces and ways to make that entire process for the patient as seamless as possible and remove as many barriers as you can to actually accessing these types of programs is the biggest component when you're looking at digital health for population health kind of work. Because I will tell you, just getting patients engaged is probably more than half of the solution. Because once you get them engaged, then you can start to see the improvement in their health. Then you can start to see them engaged in managing their own care. And you can start to then see the downstream effects of reduced admissions and, staying healthier and at home more often, and all those things that we look for when we talk about population health. But I think if you're trying to solve too many problems with digital health, then you've set yourself up for failure. So focusing on the immediate barriers and how you can make it easier for the patient to access care is, to me, in my mind, the best way to leverage digital technology to support population health.
Aaron, do you want to add anything from, again, your vantage point of just?
Yeah, I almost flipped the script on that one, because it's like, I'm tired of people saying digital health like it's some unique thing, right? It's like, it's not really, it's part of the overall care journey. And it's almost that if you don't have a digital component to it, then you're totally messing up, right? You're spending way too much money on call centers, on paper, on everything, right? So don't look at it like it's its own thing, that like, oh, the innovation group, they're taking care of digital health over here, so good luck to them, right? It's that's not right. It's digital is a part of every single patient's journey, because that's how they want, right? We don't talk about like digital banking. We don't talk about digital travel. We don't talk about digital anything anymore, because it's just part of the way we expect to interact with any institution, whether it's our healthcare system, whether it's the government, whether it's my car tabs. Like it's all needing to be as efficient as possible. And sure, healthcare is unique because there is a moment in time where you really do need to be sitting in front of somebody and say like, hey, I'm not feeling well. But even there, like there's a bookend of digital experiences that we can give that patient to help them feel better about coming in, better about leaving, and better about being at home managing their health. And I just feel like this whole like, oh, let's talk about digital health as if it's something is missing. I think that it needs to be woven into the fabric of care all across the board.
Yeah, it's just about making things easier, right? I mean, that's why we use digital technology, is to make things easier in our lives. So I think a lot of health systems tend to try to overcomplicate it in some ways. And, it's so sexy to use a digital technology solution that we make it even more difficult in some ways. So I think, focus on the actual patient itself and the care that you're trying to deliver, and then find components within that really can be, that digital technology can help improve and make easier. I think that's the better way. It's always keeping that patient workflow and that patient at the center, and allowing then the solutions to be very targeted to making that easier, versus the other way around, which is technology as a solution. We got to back into it with how we manage our patients.
Right.
I really like all that. And as a side here, this is sort of like, if you will, my space that I love as a researcher. Developing and fostering a digital culture, because we are, again, in healthcare. It's one of those things that we've been laggards. There is so much of the interaction between the patient and the physician that has been face to face. But as we start really sort of, as Aaron, you're saying, it's just part of this whole ecosystem game. So I love it. I'm going to switch gears here, because Tracy, you mentioned something which I actually wanted to sort of pull back on, and you had mentioned about that one of the areas, like say total cost of care analytics. One of those things that it's difficult to get on top of, and we have certainly seen through the Most Wired survey that is one of those digital population health activities that organizations don't lean on the EHR or the EMR for. They're looking to vendors, third-party solutions, which sort of raises the whole question then of, I know you touched on it a little bit, but really, if you could expand a little bit more in terms of just, what led to your decision to look, outside of your organization, third party, and specifically of Xealth in this case of pulling all this together.
Yeah, I kind of alluded to that in my initial introductory comments about kind of what were the three kind of questions that Xealth helped us answer in terms of improved clinical outcomes, in terms of clinical care. I think when we look at any business case and we look at any time we partner with an outside vendor, I mean, obviously, my favorite saying, the juice has to be worth the squeeze. And so sometimes it's a lot more work to actually integrate with vendors than it is to get, and then the results or the outcomes we get are actually not as much as the work it takes to actually work with them, and so you got it. It's a cost and benefit analysis that you're constantly looking at. But when you're thinking about just, does this make sense for an organization, and why we went with partnering with Xealth is we always kind of ground ourselves into the quadruple aim, which is, does this improve clinical experience? Does this result in better outcomes for the patients? Does this improve the patient experience overall? And does this lower costs? And if we kind of ground ourselves on that quadruple aim, and we can answer those questions specifically about that vendor and what their impact would be on those 4 areas, then that makes the business case a lot easier. Obviously, there's a lot more detail around workflows and what's the problem they're really helping us solve. But I think related to the Xealth partnership, you can see right away where we kind of leverage the strength of Xealth to then remove the very specific barriers we had. So I think it's really matching your barriers with what the vendor can kind of provide you. And Xealth has really been very good at identifying those barriers that they could help us remove, and then allowing us to kind of work with them on how best to do it. So I don't know if that helps answer your question.
Yeah. And actually, so I sort of feel like somewhat of the dating game here, because Aaron, I'm going to actually turn the question to you. But before we do, I do want to remind folks, if you have, we see some questions coming in, and again, we want to be judicious in our time here. But if you do have additional questions, please put them into the Q&A box. But Aaron, sort of that flip side as Xealth, what are you looking for in what makes a really good partnership, if I can sort of flip the script that way?
Yeah, I mean, I think the number one thing is recognition, like Tracy was just saying, that like, why do we need to solve this problem right now? Like, I have a digital health strategy, I got it, and I've got a nice binder, and it looks really nice, and it tells me what I should do, and I'm gonna go put it on the shelf, and when my CFO comes and asks me if I have a digital health strategy, I'll pull it off and be like, oh, absolutely, we're like all this great stuff in here. But there's just a huge gap between that and like actually interfacing and working with the rest of your organization and getting it done. And to me, it ties into like the broadest strategic imperatives for health systems, right? That post-COVID, there's like a race to regain patients, right? You've got to go find the people that used to think they were part of your health system and go get them back in for care. And then once you get them in, you need to treat them like they want to be treated. You need to make things efficient. And like, it's just kind of back to the earlier thing I said, like, you've got to understand that the digital journey there is it's no longer just like, oh yeah, my chart's pretty good. It's not enough. Like, that's not nearly enough. You're competing against a whole new range of entrants. And Tracy's right. Are you going to feel that right now? Are you going to feel it next month? Are you going to feel it this quarter? Probably not. But quarter over quarter, year over year, you really start to feel that. So for us, I mean, honestly, we just want to work with systems that are tired of having a digital health strategy and actually want to have a digital health journey that they can engage both their own C-suite on and say, look, these are the things that we need to pull off, and have that really be important. And then weave that back into the rest of the organization, because it's not just one group. It's not just your innovation group going off and doing a pilot with, Baby Scripps or Remedy. Like, that's not enough. Yeah. So we want to partner with systems that are devoted to the idea that digital health at scale is the way to get those quadruple aims met. And that's what we're looking for in terms of our partners.
Wonderful. So you get the formula for success.
Lauren, can I just add one more thing on that? As Aaron was talking, I think what's also really important, specifically at Scripps, is, you know, we obviously have kind of the top leadership looking at it from a broad level in terms of strategy. And that's really important for us because it kind of gives us that North Star, that ground, that framework to work towards. But at the same time, what is important at Scripps that we do is we also look from the ground up, meaning, does it make sense? Can it actually work for the patient? Because sometimes if it's too top down, by the time it gets to the front lines, to the patient, to the clinicians, it's a strategy that has absolutely no success, no ability to succeed because it doesn't work in the real day-to-day environment. So you've got to match the two. You've got to come from the top and the bottom and find where they actually are. There's linkages. And that's where then digital technology will really make an impact. Because without that, you're setting yourself up for failure. If it's too bottom up and it doesn't support the organizational's goals, then you've got a problem there too. So it has to be the matching between the two. And I think going through that process, and it does take time. It's not like it happens overnight. You don't just have it. You have to, it takes a lot of conversation. It takes a lot of back and forth. It takes a lot of dialogue between the various stakeholders to get to that where we can match and make it work. But that time up front avoids a whole lot of problems and failures down the road. So invest in that upfront planning and you'll avoid the, that failure of it didn't work and how did we not see this coming?
Right. Fantastic. Well, again, this is a fireside chat of sorts. I could go on and on, but I believe we have some folks have weighed in. So Steve, if I could sort of hand it back to you, I think you have been checking some of the questions and if I can put it to you and see what the questions could be addressed.
There better be some good questions out there. I'll be disappointed in this audience.
Oh, they're coming in. They have been coming in. So it's good that we saved some time here for the questions. And we'll dive right in. Tracy mentioned that, and she specifically called out the same area of health as this first question, diabetes. She mentioned that the results can take time. So with that in mind, I'll add something to the question. I will read it directly, but I'll add something that if you haven't seen it yet, maybe you can talk about your expectations. So the question is, does the increased patient access lead to improvements in areas of pop health outside of digital health? For example, do increased enrollments in the diabetes program lead to increased vaccination rates, increased prostate exam rates, et cetera?
It's a great question. I mean, there's direct correlation. So we know that patients who are on CGMs, for instance, have better adherence and probably better management of their diabetes. And again, that clinical kind of decision or that clinical support is already there. That argument's already been made. That's why we're rolling out CGMs. The issue that we always have is getting patients access to those devices, right? And then getting that information to the clinician's hands so they can do something about it and support our patients. So we're not trying to create new programs to affect patient care. We're trying to make it easier for patients to access these programs, if that makes sense. So I guess in my mind, the way I see kind of I just lost my train of thought.
Well, I'll jump in on that one because I love it. Like that, it's like, how many data sets do you need to pull in to figure out whether something's right? Let's take mental health. That's a great example, right? We all know that studies show like, oh, mental health, if people are, starting to feel more depressed because they actually have to go back into the office and it's totally depressing. So it's much more fun to work for a basement or whatever the reason is, that you're going to have, recidivism at work. You're going to, you're not going to go get the care you need from others. You might overuse the ER, but just think about like, okay, well, we need data from Qualcomm in that case. Like, okay, well, great. We improved your PHQ-9 score from 12 to 10. Okay, congratulations. Well done. What impact did that have on that patient's overall cost? I don't know. And how do you make that causal and not just sort of like loosely correlated? Like those become really challenging. So I really like where Tracy's going. You have to, we do need to measure that stuff. We do need to start putting more triggers in place. Cause Xealth, as we're going forward, like I should be able to look at a patient and say, okay, well, look, we got their PHQ-9 score down from 14 to 10. That's cool. I can just keep listening to that patient's journey, and I can see whether they showed up at the ER, and then I can see whether they came to their wellness visit. And that's data that I can report back to Tracy, so she can be like, oh, okay, cool. There's some interesting longitudinal effects, but there's so much more data that
Right.
needs to get played in there. So I think I like Tracy's, like, keep it simple, track the things we can track, and know that just generally speaking, the more digitally engaged the patient is with you, the health system, the better, the more loyal they're going to be, the healthier they're going to be. Because if they know someone's looking at that CGM data, and when I come back into the next meeting and be like, hey, look, how you doing? Let's look at your data, that they're going to be so much more disciplined and responsive about managing themselves. And there's
Yeah.
a ton of studies that prove that.
So now I remember my train of thought. So thanks, Aaron, for covering
Good.
me.
I was just giving you time. I was like, can I keep talking?
Well, I had a really like amazing thing to say, and then it just like went out of my head. But my point was that there's, we try very hard as healthcare leaders to always try to find this correlation between, if we do this, then this happens. And in some cases, it's much more diffused. If we do this and this and this and this broader thing will happen. And so I think in some ways we kind of get our own way in trying to measure, like if we deploy Xealth, we will see increased vaccinations. That may not be a direct correlation. What we do know is if we make patients give them easier access to CGM devices, for instance, we know that overall impacts their overall health and management of diabetes, which then will eventually impact their readmission rates and their acuity level and the total cost of care. So it's like you can't measure what you can in the short term, knowing that the downstream causal effect will happen. Try not to measure everything so much. So do I know our vaccination rates for our diabetes patients has increased? No, it's probably too early to know that. Do I know that the more they engage with our healthcare providers and our nurses and our staff, and they tell these patients that how important it is for them to get vaccinated, that's going to have a direct impact? Absolutely. We know that immediately. We know patients who interface with their providers and listen to their providers are very much more adherent and their outcomes are better. So I think I struggle with trying to link everything from a cause to an effect, because there's so many ways to affect one vaccination rate, for instance. And I think it's just the multitude of everything we do should have an overall positive effect. So
I'm taking that one. I'm taking that one though. I'm going to take that one. Xealth, the answer to anti-vax disinformation. Boom.
You can have it. It's yours.
All right.
So let's stay on engagement. We've got a couple of questions around that. Specifically, it says fantastic engagement metrics, and yes, heard the loading period before total cost of care impact can be measured. The question is, how long an on-ramp before the needle moves on triple aim, let alone quadruple aim, and have outcomes been materially impacted?
That's a great question. I would say there's probably a different lead time for each, and it depends on the actual disease state or care management program you're trying to, implement. So if we're looking at diabetes, for instance, longer lead time related to clinical outcomes, right? Because you have to measure it over a longer period of time to really get a sense of whether or not you're lowering their acuity level and you're being able to manage their total cost of care, because that just takes a long time to kind of aggregate that data. From a patient experience standpoint, you could very quickly be able to see whether or not these workflows work if you have a good way of measuring patient satisfaction. From an outcome perspective, on an individual level, you could probably measure very quickly whether this patient has had improved readmission rates or their physicians themselves feel like they're managing their diabetes. You can look at their A1C overall, rates, all those things you can measure very quickly. So I think it's about making sure that you don't create gates of measurements that are equal across the board for those quadruple aim areas. And again, it's always specific to the disease state you're working with. I mean, I expect to see a much higher improvement in our hypertensive patients related to any of the work we're going to do affecting their high blood pressure versus a diabetic patient whose lead time is much longer. So I think making sure you measure the time frame appropriately is important. We didn't expect to see the improvements we saw so quickly with Xealth, but I think that also speaks to the fact that the ability to enroll and engage patients has always been such a struggle for most organizations that, to be honest, I was a little skeptical because I thought, okay, we've tried everything. It's so hard to get patients engaged. But again, how do you make it easier? And if you make it easier, they will engage. It's just about that. It really is a very simple formula.
Yeah. And I'll add just a couple data points from some of our other systems. So one of them, and again, shout out to our partner with Baby Scripps. They have data that they show they can reduce NICU events in certain patient populations, and so whatever you think that number is. When one of our systems went back and looked at our deployment of Baby Scripps, they said, okay, well, look, if we look historically and see among this patient population with these clinical conditions, with these at-risk conditions, what's the normal rate of NICU events that we would expect? And they found that it was down. So the answer is 9 months. In that case, you deploy a strong maternity solution that helps you monitor and maintain connections with moms that are at risk, you're going to see that impact in NICU. And that's a true story, right? I mean, those are the things you're like, that is a huge difference. It's a difference in cost. It's a difference in a patient's experience. It's a difference in your care manager's experience. And even if that number is really small, one's enough. And those are the things that we want to try to pull off over time, but I don't think you need to wait 2 years to see the impact of some of these things.
If I can sort of weigh in too on this before we go on, again, all the years of research I've done with digital health, and one of the things I always like to remind folks is that there is a period of inefficiency that organizations experience, once you implement, and just to keep that in mind. Because it is, that quarterly report or monthly report to the C-suite, that type of thing, what's going on. That analogy of the Queen Mary turning, it does take time, but the momentum grows. So I just want to throw that out there too, is that recognize that there will be inefficiencies to start off with.
I think that's a fair statement, Lauren. I would also, though, challenge organizations to not use that as an excuse to not push forward. So manage expectations appropriately on when you should see results based on the intervention you've done, but also don't be complacent and say, well, we won't see it for a couple of years, so let's not stay diligent and measure it. So again, it's about really targeting for each of those quadruple aim components. When do we expect to see improved measured results? By what, by when, and measure that, and then through those measurements say, okay, we're either not seeing the results we expect or we are. And then that constant PDCA cycle, how do we constantly iterate and improve so that we can just make it better and better? You have to have the discipline to do that. And then that allows you to then communicate to your C-suites the appropriate expectation of when should I expect to see clinical outcomes related to this versus patient experience outcomes related to this. Totally different timelines of expectation. But it's our job to set that expectation, not the C-suite's job to tell us when to do it in a way, because we know best when to expect that. But I would not be complacent and say, oh, it's a couple of years, just, wait it out. Because to me, that gives too many people the excuse not to move quickly.
Sure.
I'm going to try to squeeze in 2 more questions since we had a bunch come in. I know that might push us a minute or so over, but let's go. What are some specific actions you are taking to accommodate personalization and health equity in this initiative? Talk about getting patients engaged, right?
So I think from an individualized standpoint, again, being able to use Xealth and digital technology to kind of have an algorithm to very specifically identify patients who meet certain criteria, who should be accessing certain programs, and then proactively communicating, I think is a way to really individualize that care, because not everybody needs access to, Baby Scripps. That's an easy one. But not everyone else needs it. I hope not everyone needs access to that. I'm sure, Aaron, you don't need access to that. But there are certain things where you want to be very targeted in the algorithm you use to identify patients who are eligible for certain things. So I think using kind of that algorithm and then targeting that communication and what you're communicating, how you're communicating is really important. I think that will help. From a health equity standpoint, think it's pretty early on. What we're doing right now at Scripps is we're really pulling the data that we have and trying to understand, the correlations between, some maybe disparities in our care or any health equity gaps to see whether or not we need to adjust how we're doing things. So we're pretty early on in that in analysis phase when it comes to health equity, but it's front and center in what we do. We're constantly trying to figure out, from a implementation standpoint, if we're doing something new, are we inadvertently affecting health equity disparity in some way? So we do have that in mind, but then using our data to either support or find other gaps, we're still in the midst of kind of processing and working through.
Yeah. I'll add one aside on that one. Okay, two, sorry. One is like being able to have access to fire interfaces lets us call and get richer data when someone schedules an appointment. So for instance, at one of our Midwest customers, we're doing transportation for Medicaid patients, right? Like, oh, I see that you're scheduling a visit. Do you need help getting here? One, it prevents the no-show rate. Two, it's giving them a coverage that they're already qualified for because we know they're Medicaid and they've indicated transportation challenges. So I think, and then the flip side on that one is, I just remember these devices, like that is the device of the working poor. They don't have access to computers. They don't have access to laptops. They can't go on and manage their health on that. You have to provide a mobile experience. A lot of times that's texting, a lot of times it's an app. So don't forget that when it comes to health equity, mobile is a huge part of that.
Right.
86% of the US population has a smartphone, and the rest of them have flip phones or something similar. So mobile communication is critical to managing your health equity story.
And speaking of communications, maybe we can end with just a little bit of the fine points on how this worked. How were the patient communications done? Was it via email? Who was the sender exactly? Was it Xealth, the partner organizations?
Yeah. First of all, we never want our vendors to communicate directly with our patients, not because we don't trust them, but because the patients trust us. They have a relationship with Scripps. They have a relationship specifically with their providers. Really important that the communication comes from us and from their providers. So we work very closely with our medical groups to make sure that if there's a specific messaging that comes from a clinician, for instance, it comes from the patient's clinician. If it's communication that's being sent, on behalf of Scripps, that it comes from Scripps. We've generally used our patient portal to push that information out. So through the portal and the email communication. So that's been our venue to send out the communication to our patients. And then of course we use, the true and tried methods of when they're in their office, we also share that information. But again, that's inconsistent. That's, it depends on the person who's communicating. And so we like to try to use our patient portal as the baseline, and then our clinicians and our staff as augmentation to that communication. Right. From an internal perspective, it was various forums. We've had discussions. We have, again, a very robust governance structure where we have conversations around our rollout schedule at the various tiers. We believe very much into the tiers of leadership. We have, tier 1, which is frontline leadership, all the way up to tier 5, which is our executive suite, our CEO. We want to make sure there's communication catered to each tier, in person as well as through written material, through training material, through email, et cetera. So we try to kind of hit all points of communication. They always say, you got to communicate at least 3 different ways, 3 different times. So.
Yeah. And it's the timing, right? It's the context of that communication that makes such a big difference, right? Like sending out something randomly to somebody and like, hey, did you know that you got this coverage for your, health plan? I'm like, okay, well, cool. You're going to get just about as much engagement as anybody else's direct marketing campaign did. But if you can get it when they just scheduled a visit or just left or just had something ordered, and you get an email or an SMS from your doctor, like, thanks, Steve, for coming in. By the way, here's the stuff we talked about. Click here, take it to your patient portal, consume that content. It's the timing and a little bit the branding, the fact that it's coming from your doctor. That's how you take engagement from, single digit percentage points or low doubles into the high doubles.
Yeah.
Certainly makes a lot of sense. And there's so many great insights and what such a fascinating case you've accomplished in a short amount of time. We appreciate everything that you shared today. Thank you, Tracy. Thank you, Aaron. Thank you, Lauren, for coming in and guiding the fireside with some Digital Health News Wired insights. Thank you, of course, to Xealth for helping us bring this webinar to the audience. And thank you to the audience for being here, for submitting great questions. We got to as many as we could. As I mentioned, this will be available on demand for you to watch over and over again because there was so much information. And just to see that beautiful scenery behind Tracy, if anything. So thank you, everyone. And this concludes today's webinar.
Thanks, everyone.
Thanks, everybody.